thought about how we could categorise infections seen in primary care in a number of ways. We can categorise them by body site. We can categorise them by the types of causative organisms, whether that be bacterial, viral, fungal, or otherwise. We need to consider them in terms of their severity. So many are mild and self-limiting, and others are more severe and systemic. We need to consider special groups with regard to infections, and these in particular are infants and children, the elderly, pregnant women, and immunocompromised individuals. We need to consider the frequency of presentation of certain infections, and of course here we are focusing on the common ones, but we must also bear in mind the less common ones, which may be the more severe or serious infections, and it's really important that we consider how not to miss those amongst all the more common and less serious ones. So I felt the most logical way to really divide up the infections in this talk was by body site. And we'll try and proceed with a few examples, a few common examples from each body site, but we will take into account things like severity, special groups, and so on. What I'd really like you to get out of this talk is really an overall approach to infections in primary care. So I've devised this schema which looks at a number of things that I think are the most important. So firstly, I'd like to highlight how we recognise the presence of infection, but also to also know when there is an absence of infection. So many of you will be familiar with the 5 cardinal signs of inflammation, so redness, heat, swelling, pain, and loss of function. It's important to remember these mean inflammation and not necessarily infection. So not everything that's red hot and swollen is infected. We know itis means inflammation and not necessarily infection. So we need to be able to distinguish between the two. Once we have decided there is infection present, we must attempt to determine the type and whether it is viral, bacterial, fungal, or otherwise. And it's not always easy to do, but we must use our clinical judgment, so the history, the physical examination, and sometimes we need other assistance to help us determine the type in the guise of microbiology. So it may be appropriate to send a sample, whether that be sputum, urine, or a swab, to the microbiology lab for microscopy, culture, and sensitivity. And it really depends on the context whether or not that is necessary. We don't get an answer immediately. That's something we need to wait for. So we may need to use our clinical judgment at the time to decide on a course of action, and then the subsequent result from the lab may subsequently affect our plan. I mentioned that determining severity was important. So we really need to, in any infection, assess the severity. So is this a milder illness, or is it more severe, systemic, or is it at risk of progressing to a more severe illness if it's not severe now? So we really need to learn how to look out for the red flags and how to assess infections. For many infections, taking a good physical exam, so judging does the patient look well or unwell, in addition to a good history, and in particular taking vital signs, taking the patient's pulse to check their heart rate, are they tachycardic, checking their respiratory rate, checking their blood pressure, as low blood pressure can be a sign of sepsis, taking their temperature. So in addition to asking them, have they had fevers at home, and we're also going to take a temperature in the clinic, and where relevant oxygen saturations and the remainder of the physical exam. Of course, all of this has become much more challenging in the context of the COVID pandemic, where many assessments are taking place over the phone. The next thing we need to think about is our treatment for any given infection, and we need to decide, is it one where we will be treating symptoms only, maybe pain, fever, or otherwise, and just observing the patient, or at least allowing them to observe at home, or are we recommending a specific treatment, prescription or otherwise, such as antibiotics, antivirals, antifungals. And we will be discussing which relevant guidelines can really assist us with our clinical decision making in terms of which treatment option to go with. Follow-up is always critical in general practice, so safety netting and either arranging a specific follow-up or making sure that the patient knows that they can return for a review if things don't improve. or indeed if they worsen. Infection control advice has always been a really important part of general practice, and of course that has come into its own in the past year, where we have been giving advice on a daily basis with people with possible symptoms of COVID. We've been very clear on our advice about self-isolating and restrictive movements. But of course, we've always done this in the context of infectious symptoms, gastroenteritis, and so on, and must advise people about the length of time for which they may be infectious and whether strict isolation is needed and whether they must stay home from work, school, or creche, and for how long. Prevention is always a big part of general practice with regard to infection. Of course, immunisation is a huge part of our job. Aside from the COVID vaccine rollout, childhood immunisations and other vaccines are a big part of our job. And of course, general advice about hygiene and hand hygiene has never been more important. I will just want to briefly mention and incorporate into the talk how we can reduce unnecessary antibiotic use. So reduce antibiotic use when it's not going to make any difference to the patient, and also to try and make our antibiotic prescribing, when we are doing it, following the guidelines and avoiding broad spectrum antibiotics in the community unless in a very small number of clear indications. So in terms of body sites, I said we'd kind of work our way through the body. I'm going to begin with respiratory infections, and associated with that the various ear, nose and throat infections linked with the respiratory tract, because really these are the most common infections we see in primary care. So you'll see in this word art, URTI, upper respiratory tract infection, is the most common type of viral illness that we see. And I have a bunch of other ones in there: lower respiratory tract infections, bronchiolitis, which is generally in the smaller infants in the winter season, croup, tonsillitis, otitis media, pharyngitis, and so on. So I'm starting with upper respiratory tract infections, and this little girl with their runny nose most likely has a common cold. I'm not going to deal specifically with COVID in this talk, and that is being dealt with elsewhere in another lecture, but we really can't go through a talk on infections without mentioning, how COVID has changed things. So of course now anybody with respiratory symptoms must undergo a COVID assessment, where the GP over the phone will determine if they meet the criteria for testing and self-isolation and so on. So really everyone with respiratory symptoms is assumed to have COVID until it is ruled out. And even at that, if their symptoms persist, there is still isolation advised until they are well clear. So in this case, we'll take this as sort of pre-COVID, this young girl with a runny nose and low-grade fevers. So this is a common cold. And the virus you see here, we now know that every man on the street will recognise a spiky ball as a virus. So this one here is not COVID-19, but it is a rhinovirus. So most common colds are caused by coronavirus families, rhinovirus, RSV, parainfluenza. Okay, and they've been around for many years, and we did see a lot less of them this year in the context of people self-isolate, or at least social distancing, and with all the hand hygiene. Generally mild and self-limiting. Many people with common colds do not present to us in primary care and will self-manage at home, but some people will present to us, or they may, and I know I'm speaking to people in a variety of different professions, so often people will present to the pharmacist with a common cold looking for symptomatic treatment. If we do see people with it, we need to advise them that their symptoms will typically last 7 to 10 days, and we're really focusing on symptomatic treatment. And most members of the public will appreciate that antibiotics have no role in the common cold. The head colds do have a bit more significance for people with respiratory conditions. Asthma in particular is very vulnerable to triggers by head colds. So people with asthma will often have a flare or exacerbation in the winter months with a common cold. And as GPs, we will often manage these. And patients with asthma also need to know how to self-manage their flares and when they should present to a healthcare professional. So influenza, of course, another very common viral respiratory illness. Amazingly, in the past season, there have been no cases reported in Ireland, according to Public Health. So this is something we would normally see a lot of every year between kind of November and March in general practice. And because people are generally quite unwell with it, they generally will present to us as the GP. Sometimes people ask, how can we distinguish flu from the common cold? And certainly pre-COVID, this was always very easy. It was always quite clear when we were dealing with flu. Sudden onset, high fevers of 38 and above, usually for 5 to 7 days. People feel really miserable with it, muscle aches and so on, in addition to symptoms similar to the common cold, whereas the common cold tends to have lower grade fevers, not as persistent, comes on more gradually, and the symptoms are overall much milder. This is something that we generally advise, again, symptomatic treatment, but often people need quite regular paracetamol, possibly with ibuprofen, to manage their fevers and pain. A smaller proportion of people in vulnerable groups may need antiviral treatment, and a smaller proportion, again, will need hospitalization, and we need to judge based on the person's symptoms, their heart rate, their hydration status, and their vulnerability, and who may require hospitalization. And this is only required in a small minority. And we do know that every year there is a death rate associated with influenza. So moving on to middle ear infections, otitis media. So in this image here, you see the eardrum bulging with pus behind it. Really, otitis media can be caused again by viral or bacterial causes, and it's not always easy to distinguish between them. We have to kind of really consider otitis media as one where we shouldn't often give an immediate prescription for antibiotic, and it's a very good example actually where delayed prescribing of antibiotics can be utilised. So this means giving a prescription for an antibiotic, but advising the person who is usually a parent, because this is usually a condition of young children, to hold off on filling the prescription and giving them instructions as to what to watch out for and when they would consider filling it. So, for example, if they present in the early stages of an otitis media, you may give a prescription following the antimicrobial prescribing guidelines and advising that if the pain or fevers have not settled in either 24 or 48 hours, depending, that they would consider filling it at that point. So this is a method that we've been using as GPs for years now. Initially, some people were skeptical and thought if you give somebody a prescription for antibiotics, they're going to go and fill it straight away. And evidence has shown that is not the case. This BMJ article showed that 40% less antibiotics were used with the delayed prescription method. And that was in the case of respiratory tract infections. And it looked at the outcomes between delayed prescribing or no prescribing. And in these, there were similar outcomes to immediate prescription. There's another, I think it was the Cochrane database have some interesting meta-analyses looking at outcomes for delayed, immediate or no prescribing for various respiratory symptoms. So one study found no difference between any of those methods for people presenting with cough, and similar findings in relation to otitis media. Now, of course, we need to use our clinical judgment, and if we think that bacterial infection is likely and the symptoms are severe, we are going to go ahead with immediate antibiotics. But it's really for the somewhat more vague symptoms where it's not so easy to distinguish between viral and bacterial, where we may consider this delayed prescribing or no prescribing of antibiotics. And if you're doing no prescribing, of course, safety netting is important, that the patient knows they can present, to you again for a review if things don't improve. So there is, an option for them to return. So the important thing really with something like otitis media is focusing on symptomatic treatment, so pain relief. So with a child, we're talking about paracetamol, liquid or rectal paracetamol, ibuprofen, and giving those, which will help both with pain and fever. And in fact, topical analgesic ear drops can be very effective for pain, and there is very good evidence for those, and they're very underutilized. And often people think that ear drops have no role in otitis media because the ear canal is a cul-de-sac, but the eardrum is very, very, it's a very fine surface, and topical local anaesthetic will provide pain relief. So that's something to bear in mind. Tonsillitis, something we see very commonly as well. We see here in the image large swollen tonsils with white spots of exudate. Again, it's not always easy to distinguish between viral and bacterial causes, but we do have some criteria that guide us. So we use the Centaur Criteria, that's CENTOR, and that has a number of criteria that would make bacterial infection, usually streptococcal, more likely. So the absence of a cough, the presence of fever, the presence of tender swollen lymph nodes, all of those things make a bacterial cause more likely, whereas if there is coexisting cough and upper respiratory symptoms, no fever, and so on, all of those things make it more likely to be viral. Okay, and typically the bacterial ones really have sudden onset, whereas viral is more gradual. The presence or absence of exudate does not necessarily swing it either way for us. We do more often see the exudate, which is the white pus coating the tonsils, with bacterial ones. But bear in mind, you can have a streptococcal throat with no exudate, and you can have exudate with viral causes, with a number of viral causes. And one example of this is Epstein-Barr virus, also known as infectious mononucleosis or glandular fever. So with this, the exudate tends to be quite confluent, covering the tonsils. So it's always something to bear in mind. Sometimes we may only make that diagnosis in retrospect. If the patient doesn't respond to a course of antibiotics, we may then consider doing a blood test, serology for Epstein-Barr virus or the monospot test, depending on the age of the child or patient. So actually, just to move back to the tonsillitis, this is a good example for me to just show you the antimicrobial prescribing guidelines. So I'm just going to share my screen with you for a moment. So once we've decided that the patient needs antibiotics, we should consult the guidance unless we're very familiar with the current ones. Because they do change regularly, and in fact, the duration of treatment for penicillin for tonsillitis has changed. So I'm just going to go into conditions and treatment. So this is a really excellent resource, and I'd really recommend that everyone becomes familiar with it, even if you're not in a prescribing role. It's just good. There's a lot of very good information about appropriate treatment for common infections. So you'll see that they give kind of guidance in terms of, when sore throats may be viral, and that you're unlikely to get complications from withholding antibiotics. And of course, if you think complications or advanced tonsillitis is present already, you won't withhold. So if we go down to the first choice, it's phenoxymethylpenicillin. It gives the dose and the duration, which is now 5 days. It was previously 10, and really there was very poor adherence rates with that longer regime. And of course, we're always going to check about penicillin allergy and give the alternative in that case. And it gives specific choices for children. Okay, so as I say, definitely have a look around that resource. I'm just going to put my slides back up. So this next one is related to the streptococcal throat. So this is a rough sandpapery maculopapular rash. Maculopapular meaning red raised bumps, and it does blanch when you rub across it. So this is scarlet fever, so a very common illness of childhood. So we suspect this when we see this very characteristic rash, and children may also have what we call a strawberry tongue with it as well. This can happen post-streptococcal throat or during a streptococcal throat infection, and it's the body's reaction to the toxins from the bacteria. So children may not complain of a sore throat, but we always examine the throat, and we'll usually
pharmacological and non-pharmacological management strategies Patients with COPD and indeed other forms of chronic lung disease have experienced an extremely challenging time over the past year during a global pandemic, which we know is caused by a virus that attacks the respiratory system. In this presentation, I will discuss an up-to-date review of the management of patients with COPD in the context of recently published international guidelines and research studies, and in the context of this ongoing pandemic. I will begin the presentation by briefly discussing what COPD is and how it impacts patients and our healthcare system. I'll then discuss a suggested approach to management of COPD, starting with the initial assessment and diagnosis, and how this is really key in guiding initial treatment. I'll then discuss the management of COPD in more detail in the context of non-pharmacological and pharmacological approaches, and also focusing on recent developments, such as the role of blood eosinophils, inhaled corticosteroids, and triple therapy. After discussing approaches to the management and prevention of COPD exacerbations, I will discuss COPD in the context of the pandemic and how COPD can be managed at this time in terms of stable disease, but also in terms of exacerbations and coexisting COVID-19 infections. I'll then finish by briefly discussing some potential future developments in the management of COPD. So, what is COPD? Well, chronic obstructive pulmonary disease is traditionally defined as a preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities. COPD may be perhaps better defined as a clinical syndrome, which is characterized by chronic respiratory symptoms, structural abnormalities, which can be airways disease, emphysema, or both, lung function impairment, which is primarily airflow limitation that is poorly reversible, or any combination of these. The most recent symptoms, the most common symptoms are dyspnea, cough, and/or sputum production. The most common risk factor, as we know, for COPD is tobacco smoking, but other environmental exposures, such as biomass fuel exposure and air pollution, are likely to contribute. Other factors, such as genetic factors, such as alpha-1 antitrypsin deficiency, asthma, and lower socioeconomic status, are also associated with an increased risk of developing this disease. Although COPD affects the lungs, it also has significant systemic consequences. Many patients experience acute worsening of symptoms known as acute exacerbations. Exacerbations and comorbidities are important contributors to the overall condition and prognosis in individual patients. COPD is a major and increasing cause of mortality and morbidity throughout the world. Based on data from the BOLD program and large epidemiological studies, COPD was estimated to have a global prevalence of 11.7% in 2010, causing 3 million deaths per annum. Due to the expanding epidemic of smoking in developing countries and an aging world population, COPD is expected to cause 5.4 million deaths in the year 2060. COPD also has a massive economic cost. Approximately 3.5% of the EU's entire healthcare budget, 38.6 billion euro, is spent on COPD every year. The prevalence of COPD in Ireland is unknown. However, we do know that COPD is a significant cause of morbidity and mortality in Ireland. In fact, it is second only to lung cancer as a cause of death from respiratory disease. It is also responsible for more deaths than any other non-respiratory cancer. It exerts a significant economic cost, and indeed in 2016, among those with GMS eligibility, medication costs for COPD were 67.6 million euro, COPD is therefore a disease which exerts a major impact on patients and healthcare systems in Ireland and across the world. So as shown on this graph, which is published by the Irish Thoracic Society, the number of patients hospitalized with a primary diagnosis of COPD has increased over the past number of years and continues to increase. So what is the recommended approach to the diagnosis and assessment of COPD in 2021? Well, there are several published guidelines, such as from the Irish, British, European, and American thoracic societies on the management of COPD, but perhaps the most up-to-date and the most commonly referenced by those involved in the management of patients with COPD is the Global Initiative for Chronic Obstructive Lung Disease, or the GOLD report. As many of you may know, GOLD publishes a yearly report with evidence-based recommendations but based on the most recent up-to-date published research in the area of COPD. For the purposes of clarity, I will make reference to these guidelines throughout the presentation. To start, the most recent 2021 GOLD report continues to recommend that a diagnosis of COPD is based on the presence of symptoms and airflow obstruction, as demonstrated by a post-bronchodilator forced expiratory volume in 1 second, or FEV1, over FVC, which is the forced vital capacity. Ratio of those two factors of less than 0.7 is required. That indicates airflow obstruction, and or reported risk factors for COPD, such as smoking. The GOLD report also states that the goals of assessment are to determine the level of airflow obstruction, as shown on spirometry, the impact of the disease on the patient's healthcare status, and this is determined by the magnitude of the symptoms, and the risk of future events, such as exacerbations, comorbidities, hospital admissions, or death. Therefore, the recommendation is that spirometry and the extent of the spirometric abnormality, the severity of symptoms, comorbidities, and a history of exacerbations are all key elements of the assessment of a patient with suspected COPD. On the right here, we see a flow volume loop which is performed during spirometry. And the expiratory flow volume loop of on the left here in panel A is normal. However, on the right, we see the characteristic concave shape that is seen in a patient with airflow obstruction. It has a kind of scooped out appearance, as you can see. And this would be diagnostic of COPD in a patient with symptoms and or risk factors for the disease. Excuse me. This figure is taken from the current or most up-to-date GOLD report, and it illustrates the initial recommended approach to a patient with suspected COPD. Patients with suspected COPD should undergo spirometry, a post-bronchodilator FEV1 to FVC ratio of less than 0.7, as I mentioned, is diagnostic of COPD in patients with symptoms and or risk factors. The degree of FEV1 impairment, expressed as a percentage of the predicted value, is then used to determine the GOLD stage. So, for example, here we see the initial response, the initial post-bronchodilator ratio of 0.7, then assessing the level of airflow limitation. And this gives us the stage, which is based on the level of FEV1 impairment. So an FEV1 of greater than or equal to 80% would be GOLD, stage 1. The level of symptoms is then the next factor that we need to look at. And this is determined by the modified MRC breathlessness score, or MMRC, and or the COPD assessment test, or CAT score, and the risk of exacerbations. And this is based on the number of moderate or severe exacerbations in the previous year. So these factors are used to determine the patient's GOLD group, which can be either A, B, C, or D. As I will discuss a little bit later in the presentation, it is this combination of GOLD stage, which is based on spirometry, and GOLD group, which is based on exacerbation history and symptoms, that is a crucial factor in determining the initial treatment approach. In the past, a measure of breathlessness was considered to be an adequate measure of symptoms in COPD, but we now know that COPD impacts patients beyond breathlessness. And this slide shows the two most commonly used and practical measures of assessing symptoms in patients with COPD. And on the left, we have the Modified Medical Research Council score, and on the right, we have the COPD assessment test, which is a measure of health status impairment in COPD. The following investigations should be considered as part of a diagnosis and assessment of patients with suspected COPD. A chest X-ray should be considered in all patients with COPD. And the main reasons for this are to exclude other causes of respiratory symptoms, such as cardiac failure or pleural disease, and to outrule other concomitant chest pathologies, such as lung cancer, which we know is more common in patients with COPD. And here we see the characteristic chest X-ray signs of COPD. We see hyperinflated lungs with relatively flattened hemidiaphragms. We see the hyperlucent lung fields and tapering of the blood vessels as they go more peripherally. Sputum culture should be performed in certain situations, especially during exacerbations and if there is severe airflow limitation. Pulse oximetry is very useful to assess a patient's arterial oxygen saturation and their need for supplemental oxygen therapy. An ABG should be performed if peripheral oxygen saturation is less than 92%. According to the World Health Organization and the European Respiratory Society, screening for alpha-1 antitrypsin deficiency should be performed at least once on all patients with COPD. Correct diagnosis of COPD and detailed assessment of the impact of this disease on individual patients, as described, are essential to ensure that patients receive the optimal management. This figure is taken from the 2021 Goals report, and it illustrates these important first steps in the assessment and management of COPD patients. I think this figure also illustrates the most recent and evidence-based holistic approach to COPD management, which incorporates a combination of non-pharmacological, such as smoking cessation, risk factor reduction, vaccination, and pharmacological approaches. As shown in this figure, individual patient factors such as symptoms, exacerbations, comorbidities, treatment effects, adverse effects, inhaler technique, and compliance should be periodically reviewed. And consequently, both pharmacological and non-pharmacological therapy should be adjusted based on these regular reviews if that is indicated. Optimal COPD management therefore incorporates non-pharmacological and pharmacological interventions. The key intervention in COPD management is smoking cessation. Smoking cessation significantly reduces the rate of progression of the COPD, the risk of malignancies, and it also reduces the risk of coronary and cerebrovascular diseases. Even brief smoking cessation counseling has been shown to be effective and all smokers should be offered this at every review. Indeed, there appears to be a dose-response relationship between the intensity of smoking cessation counselling and quit rates. In other words, the more intense the counselling, the higher the quit rate. Where possible, patients should be referred to a smoking cessation program that incorporates behavior change techniques that enhance motivation and confidence, education, pharmacological and non-pharmacological techniques. Patients should be offered pharmacotherapy unless contraindicated, and options include varenicline, bupropion, nicotine gum, inhaler, spray, or patches. This slide illustrates the 2A's and 5A's of smoking cessation, which I think is a practical approach to smoking cessation that can be readily incorporated into clinical practice in both primary and secondary care. The 2A's, or ask and act approach, is endorsed by the American Academy of Family Physicians, and it involves asking about smoking behavior and acting to assist quit attempts. The 5A's approach is suggested by Gold, and it represents a brief, practical, and effective approach to smoking cessation counselling. Vaccination is another important element of COPD management. The influenza vaccine should be administered annually. This has been shown, this has been shown to reduce serious illness, exacerbations, and death in patients with COPD. Pneumococcal vaccination with the PCV13 or PPSV23 vaccine is recommended for all patients who are 65 years of age or older. And Gold also recommends that the PCV13 vaccine is also recommended in younger patients with significant comorbidities such as heart or lung disease. Interestingly, the most recent Gold report now includes a recommendation from the CDC in the US that the Tdap vaccine, or pertussis tetanus diphtheria vaccine, should be administered to all adults with COPD who are not vaccinated during adolescence to protect them against pertussis or whooping cough. Self-management involves a personalized, structured intervention that seeks to motivate and support the patient to develop skills to better manage their disease. Examples include inhaler technique and compliance, exacerbation, action plans, and several systematic reviews have shown that self-management interventions improve outcomes in COPD. For example, a Cochrane review of self-managed action plans for exacerbations of COPD demonstrated improvements in health-related quality of life for hospital admissions. Physical activity levels are reduced in patients with COPD, and this is associated with a reduction in quality of life, increased hospitalization rates, and increased mortality. Technology-based interventions have the potential to provide education and to motivate and provide accessible ways to assist COPD patients to increase their physical activity levels. The ongoing pandemic has shone a light on this area, and further research is required to establish the most suitable interventions. Alternatively, a structured exercise training plan using a combination of constant load or interval training with strength training has been shown to increase physical activity levels in patients with COPD. Pulmonary rehabilitation is a comprehensive set of interventions which include the aforementioned self-management interventions and exercise training. Patients with a high symptom burden and risk of exacerbations, in other words, patients in Gold groups B, C, or D, should be offered formal pulmonary rehabilitation. There are three key time points when we should consider pulmonary rehabilitation referral. That is, at the time of diagnosis of COPD, at discharge following hospitalization, and or if symptoms are deteriorating despite optimal medical treatment. Pulmonary rehab is typically run over a 6 to 8 week period with supervised exercise training at least twice weekly. It has been shown to have multiple benefits in COPD patients, including improvements in dyspnea, health status, exercise tolerance, and anxiety, depression levels. Review of a patient's nutritional status should be performed at each patient review, as some patients with COPD, especially those with severe disease, have been shown in studies to be quite malnourished. These patients require additional nutritional support. Patients with moderate to severe disease should be reviewed for long-term oxygen therapy. And I've shown the criteria, which many of you will know, for a prescription of long-term oxygen therapy here. Once commenced on long-term oxygen therapy, patients should be reevaluated in 2 to 3 months' time. Non-invasive ventilation can be considered in carefully selected patients with severe COPD, such as those with marked daytime hypercapnia and recent hospitalization. Patients with COPD and sleep apnea should be considered for CPAP therapy. Lung volume reduction, which can be either bronchoscopic or surgical, can be considered in carefully selected patients with severe hyperinflation. Patients with advanced symptomatic COPD should be referred for palliative care support with regards to symptom control, psychosocial support, and end-of-life planning. So in summary, these non-pharmacological interventions, such as smoking cessation, vaccination, self-management and education, inhaler technique and compliance, pulmonary rehabilitation and oxygen assessment, are important elements of the initial and the ongoing management of patients with COPD and should be tailored on an individual basis according to each patient's needs. So now I will move to the pharmacological management of COPD according to the most recent guidelines and evidence base. The importance of assessing the severity of each patient's symptoms and their exacerbation risk was discussed a bit earlier in this presentation. As shown in this figure from the 2021 GOLD report, initial pharmacotherapy should be based on the patient's GOLD group, which is determined by their level of symptoms and the number of exacerbations that they have experienced in the preceding year. Bronchodilators, such as LAMAs, or long-acting muscarinic antagonists, or LABAs, which are long-acting beta-2 agonists, are the recommended initial treatment for patients in GOLD group A, B, and C. The choice of initial therapy for patients in GOLD group D, so that's those who are most symptomatic and those who are experiencing exacerbations, depends on a couple of factors. It depends on the intensity of their symptoms, and it may also be influenced by their blood eosinophil level. So, for example, those who are highly symptomatic should be considered for a LABA-LABA combination. Those who have higher circulating blood eosinophil levels should be considered for an ICS-LABA combination. Excuse me. Indeed, peripheral blood eosinophilia has been identified as an important biomarker in COPD and is associated with an increased incidence of COPD exacerbations and mortality. In recent years, the blood eosinophil count has been identified as a circulating biomarker to help maximize the benefit and minimize the risk of using inhaled corticosteroid therapy, or ICS therapy. A number of studies have shown that blood eosinophil counts predict the magnitude of the effect of the ICS, which is added on top of an inhaled maintenance bronchodilator, in reducing the risk of future exacerbations. Indeed, there seems to be a continuous relationship between blood eosinophil counts and the efficacy of ICS use. No or small effects are seen at low eosinophil levels, with incrementally increasing efficacy seen at increasing eosinophil levels. Data modeling has identified estimated cutoff values for circulating eosinophils and ICS efficacy. So, ICS bronchodilator inhalers are likely to have little or no treatment effect, with circulating eosinophil counts less than 100 cells per microliter. In contrast, patients with blood eosinophil counts more than 300 cells per microliter are most likely to experience a treatment benefit and reduction in their exacerbation risk. I think this is a key factor. Thus, although there are no high quality randomized control trial evidence for initial pharmacotherapy strategies in newly diagnosed COPD patients, the current goals recommendation is that a combination of LABA ICS therapy should be considered in patients who are very symptomatic and have an exacerbation of or have a history of exacerbations and or a high blood eosinophil count, more than 300 cells per microliter. And evidence for this comes from an observational population-based cohort study that evaluated newly diagnosed COPD patients that were started on either a LAMA or a LABA-ICS combination over a 13-year period. Patients were monitored for 1 year for the presence of moderate to severe exacerbations and or pneumonia. And this figure illustrates the adjusted hazard ratio of moderate to severe COPD exacerbations with LAMA ICS treatment according to the blood eosinophil count. So above this horizontal line here favors LAMA inhalers, while below this horizontal line favors LABA ICS combinations. And as shown, initial COPD treatment with LABA ICS inhalers was only more effective than with LAMAs in patients with high blood eosinophil concentrations greater than 4% or counts greater than 300 cells per microliter. So, at this point here. It should also be highlighted that the incidence of pneumonia was increased in the LABA ICS combination group. The hazard ratio was 1.37 in that particular group and was similar across all eosinophil concentrations. However, the benefit of LABA ICS inhalers and treatment on exacerbations outweighed the risk of pneumonia with an eosinophil concentration threshold greater than 4%. Thus, initiation of inhaled corticosteroid therapy in combination with bronchodilator therapy should be considered with higher circulating levels of blood eosinophils in COPD patients. In addition, studies have shown that the treatment effect of ICS regimens, whether that be in combination with a LABA and LAMA, or LABA ICS or LABA LAMA, is higher versus LABA LAMA, is higher in patients with a higher exacerbation risk. The higher exacerbation risk is deemed to be 2 or more moderate exacerbations or 1 hospitalization with COPD exacerbation within the previous year. And that is why exacerbation history should always be considered in addition to the eosinophil count when considering initiation of an ICS regimen. However, ICS use, as mentioned, is associated with adverse events and should always be initiated with caution. Previous randomized control trials have shown that ICS treatment is associated with oral candida, hoarseness, pneumonia, cataracts, and diabetes. This table, which I took from a paper published in the European Respiratory Journal, nicely summarizes the points which should be considered when ICS regimens are being considered. a history of COPD hospitalizations or exacerbations, and or higher eosinophil counts provide stronger use for the use of ICS therapy. Whilst patients who have a history of recurrent pneumonia events or mycobacterial infection or lower blood eosinophil counts, there's less support for ICS use in such patients. In addition to review of non-pharmacological interventions such as smoking cessation and pulmonary rehabilitation, evaluation of the patient's response to previously initiated pharmacotherapy is extremely important. If the patient is continuing to have problems with their symptoms despite the initial therapy that was previously commenced, then treatment should be modified. And this algorithm, which is taken from the most recent GOLD guidelines, I find is quite useful, and it requires the clinician to basically identify what the predominant treatable trait is. So in other words, is dyspnea the main issue, or is it exacerbations, or is it a combination of both? It also helps the clinician to consider and reevaluate the current therapy that the patient is receiving. The clinician should then use either the left side of the figure or the right side, depending on what the predominant main symptom is. So if patient is continuing to have, for example, significant dyspnea, we would use the left side, exacerbations the right side. So, for example, with patients who are experiencing exacerbations as a primary symptom, a LABA or a LAMA inhaler can be then escalated to a LABA-LAMA combination if there's ongoing exacerbations, or a LABA plus ICS, particularly if there's higher blood eosinophil counts, as previously mentioned. De-escalation of inhaled corticosteroids or a switch should be considered if the patient has experienced pneumonia, if there was an inappropriate original indication for ICS use, or if there was a lack of response to the ICS. And this figure also shows how a step up in treatment to triple therapy, which is a combination of LABA, LAMA, and ICS, can occur. And there's various approaches to this, but specifically severely dyspneic patients on LABA ICS therapy, or patients experiencing exacerbations despite LABA, LAMA, or LABA ICS therapy should be considered for fixed dose triple therapy. So the evidence for this step up in treatment comes from multiple studies which have shown that fixed dose triple therapy has been shown to improve lung function, patient-reported outcomes, and reduce exacerbations when compared to LAMA alone, LABA-LAMA combinations, and LABA ICS therapy. One such trial was the IMPACT study, which was a randomized control trial of 10,355 patients with COPD and was published in the New England Journal of Medicine. Over the course of a year, patients were randomized to receive once daily combination of fluticasone furoate, which is an inhaled glucocorticoid, umeclidinium, which is a LAMA, and vilanterol, which is a LABA, as triple therapy, or a combination of the steroid and the LABA, or a combination of the LABA-LAMA. The primary outcome was the annual rate of moderate or severe COPD exacerbations during treatment. And as shown on the top figure here, there was a significantly lower rate of COPD exacerbations in the triple therapy group compared to the LABA ICS and the LABA-LAMA group, with exacerbation rates of 0.91 in the triple therapy group compared to 1.07 in the LAVA ICS group compared to 1.21 in the LAVA LAMA group. As shown in the second figure here, patients on triple therapy were also shown to have a lower risk of exacerbation, and this is shown in a time to first exacerbation analysis. So you can see that the triple therapy group had a significantly lower risk of exacerbations compared to the other two treatment groups. So from this we can, or this data suggests that triple therapy is most likely to be effective in those who are severely symptomatic with their COPD, those who have moderate to very severe airflow obstruction, or patients who have a history of frequent and or severe exacerbations. Furthermore, recently published analyses of the IMPACT trial data and the large ETHOS randomized controlled trial, which had over 8,000 patients in it, provide further evidence that suggests that triple therapy with fixed dose inhaled triple therapy combinations actually reduces mortality compared with dual therapy. Both trials were enriched for symptomatic patients with a history of frequent and or severe exacerbations, and they compared triple therapy at 2 ICS doses in the case of the ETHOS trial to 2 dual therapy options, which are or were LAVA LAMA and LAVA ICS. Mortality was a pre-specified outcome for the trials, but not a primary endpoint for either study. And as shown on this Kaplan-Meier analysis taken from the IMPACT study, mortality in the triple therapy arm was significantly lower compared with the dual therapy arm. In the ETHOS trial, mortality was significantly lower in the triple therapy group at the higher ICS dose compared to the other treatment groups. Thus, the current GOLD 2021 report concludes that triple therapy is likely to have a beneficial effect on mortality in symptomatic patients with a history of frequent and or severe exacerbations. Further studies or analyses may help to determine if other patient subgroups in COPD obtain a mortality benefit from triple therapy. Now to exacerbations. So treatment and prevention of acute exacerbations is one of the key elements of effective COPD management. And if an exacerbation of COPD is defined as an acute worsening of respiratory symptoms that results in an increase in additional therapy. Exacerbations are typically triggered by viral infections, most commonly rhinovirus, although bacterial infections or environmental factors such as air pollution and ambient temperature may also trigger or amplify exacerbations. Symptoms typically last for 7 to 10 days. However, 20% of patients will not recover to pre-exacerbation status by 8 weeks. Exacerbations thus have a significant negative impact on patients' health status, on rates of hospitalization and readmission, and they are associated with disease progression. The strongest predictor of exacerbation risk is the number of exacerbations in the previous year. Hence, as previously mentioned, a detailed exacerbation history is a key element of the initial and ongoing management of patients with COPD. Many of you will have considerable experience treating exacerbations of COPD in primary care, and for the purposes of this presentation, I will focus on primary care management. The first key point is to always consider an alternative diagnosis which can have a very similar presentation, such as pneumonia, pneumothorax, pulmonary edema, and PE. Treatment of exacerbations is centered on bronchodilators, corticosteroids, and antibiotics, and there has been no major change in the guideline-based advice for these treatments in recent years. Despite a lack of randomized control trial evidence, short-acting beta-2 agonists and or short-acting anticholinergics are recommended as first-line treatment for acute exacerbations. The recommended dose is 1 to 2 puffs of the MDI inhaler per hour for 2 to 3 doses, then every 2 to 4 hours based on clinical response. If nebulizers are given, air-driven rather than oxygen-driven nebulizers should be used in order to prevent oxygen-associated CO2 retention. Usual inhaled medications should be continued during exacerbations or restarted prior to discharge if they're hospitalized. Glucocorticoids have been shown to shorten recovery time and improve lung function, as determined by FEV1, in patients experiencing an acute exacerbation of COPD. They have also been shown to improve oxygenation, length of hospital stay, risk of early relapse, and treatment failure. The recommended dose of prednisolone is 40 milligrams once daily for 5 to 7 days. However, it should be pointed out that even short bursts of glucocorticoids are associated with an increased risk of pneumonia and death, and hence are only recommended in patients with significant exacerbations. Although the evidence for antibiotic use in exacerbations is somewhat uncertain, antibiotics are recommended in exacerbations of COPD if the patient is experiencing an increase in sputum purulence with an increase in dyspnea or sputum volume. The choice of antibiotics should be based on local resistance patterns, and coamoxiclav or macrolide or tetracycline are the typical broad-spectrum empiric choices. Antibiotics are generally recommended for 5 to 7 days. A sputum sample should be sent for culture if the patient has severe disease, a history of recurrent exacerbations or mechanical ventilation, to screen for gram-negative or resistant organisms. Prevention of further exacerbations is a key element of COPD management, and preventative strategies that I have already discussed earlier in this presentation include smoking cessation, education, inhaler technique and compliance review, vaccinations, pulmonary rehabilitation, and regular maintenance bronchodilator therapy, with consideration for inhaled corticosteroid if frequently exacerbating and or higher eosinophil levels are present. Prophylactic macrolide antibiotics, especially in non-smokers with recurrent exacerbations, should be considered. For example, azithromycin has been shown to reduce exacerbations compared to usual care. The immunomodulatory role of vitamin D has also been implicated in the pathophysiology of COPD exacerbations, and COPD is associated with lower levels of vitamin D. Vitamin D replacement in cases of severe vitamin D deficiency has been shown to reduce the risk of future exacerbations and hospitalizations by 50%. Thus, vitamin D assessment and treatment, if indicated, is recommended in all patients who are hospitalized with COPD exacerbations. So now to COVID-19 and COPD. So the COVID-19 pandemic has led to many challenges and uncertainties for the management of COPD, as well as a number of concerns for patients. The evidence for the interaction between COVID-19 and COPD is limited, but it is constantly evolving and growing. Based on the limited body of evidence to date, it would appear that patients with COPD do not appear to be at a greatly increased risk of infection with SARS-CoV-2. This may be due to protective strategies such as social isolation and public health measures and improved air quality, and also possibly due to healthcare avoidance. patients with COPD appear to be at a slightly increased risk of hospitalization for COVID-19 and may be at risk of developing severe disease or death, although the evidence for this is contradictory. The highest risk of severe COVID disease or death would appear to be in active smokers with COPD. Interestingly, most of the published data so far suggests that the number of hospitalizations with exacerbations of COPD has declined during the pandemic. For example, data relating to the first wave of COVID-19 in Ireland showed that the number of patients admitted with exacerbations of COPD had declined by 49% to the same time in 2019. This recently published data from South Korea shows a similar finding. It shows a sharp decline in the actual number of hospitalizations with exacerbations of COPD, shown by this red line, compared to the expected number of hospitalizations with COPD, as shown by the blue line, compared to previous years. And again, the effects of protective strategies and possibly healthcare avoidance are likely to be at play here. So how should patients with stable COPD be managed during this ongoing pandemic? Based on the limited amount of available evidence, the most recent GOLD report recommends that patients with COPD should follow basic infection control measures such as social distancing and hand washing, wear a face covering, and indeed studies suggest that wearing a surgical mask does not actually affect ventilation, even in patients with severe airflow limitation. Patients should also be advised to keep as active as possible during public health mediated lockdown periods. In line with guidelines, the number of face-to-face visits has reduced significantly during the pandemic in both primary and secondary care, and remote consultations using phone and online video calls have become commonly used. The GOLD 2021 report recommends that spirometry should be restricted to urgent or essential situations only, such as prior to interventional procedures or surgery. Patients should be advised to continue their maintenance bronchodilator therapy at this time. As discussed earlier in the presentation, we know that inhaled corticosteroids should be used in patients at risk of exacerbations, but I also show that ICS therapies are also associated with an increased risk of pneumonia. Therefore, should ICS therapies be used during the pandemic? The answer to this question would appear to be yes, as there is no conclusive evidence to suggest that ICS reduces or increases the risk of COVID pneumonia. Other areas to focus on in primary care are to ensure that patients receive their annual influenza vaccination, smoking cessation, and that they maintain physical activity supported by home-based pulmonary rehabilitation where possible. Coronaviruses are well-recognized triggers of seasonal COPD exacerbations. However, interestingly, MERS, SARS-CoV, and SARS-CoV-2 or COVID-19 have not been reported in COPD exacerbations. Also, it is clear from imaging and post-mortem studies that the pathology of a typical acute exacerbation of COPD is very different from the viral pneumonia, which is typical of COVID-19. Thus, conceptually, COVID-19 infection in a patient with COPD is likely to be a very different pathophysiological process. Clinically distinguishing between a COPD exacerbation and a COVID-19 infection can be difficult, as cough and breathlessness are found in over 60% of patients with COVID-19. Potential clinical discriminating factors include fever, which is present in more than 60% of patients with COVID-19 infection, fatigue, confusion, diarrhea, nausea, vomiting, muscle aches and pains, anosmia, dysgeusia, and headaches, are obviously all more common and prevalent in COVID-19 infection. If there is any doubt, of course, a PCR test should be performed. The general approach to COPD and COVID-19 infection is as follows. Management of COPD exacerbations during the pandemic is essentially the same as before. If COVID-19 infection is detected, then treatment for the COVID-19 infection should be conducted regardless of the presence of COPD. This figure was taken from recently published publication in the Blue Journal, and it illustrates the approach to the management of COPD exacerbations and COVID-19 infections in patients with COPD. Patients with COPD and mild COVID-19 infection are treated with their usual COPD therapy and COPD exacerbation therapy. In addition, obviously, to the usual protective strategies and exercise. A chest X-ray is indicated in patients with moderate to severe symptoms of COVID-19, and those with hypoxia and infiltrates should be treated with controlled oxygen, systemic steroids, which is typically dexamethasone rather than prednisolone in the case of COVID-19, remdesivir, and anticoagulation. Those with severe disease may require NIV, high-flow nasal therapy, and or prone positioning, and in some cases, intubation with mechanical ventilation. Rehabilitation should be provided to all COPD patients recovering from COVID-19 infection. So the COVID-19 pandemic has certainly challenged all of us who are involved in the management of patients with COPD to reevaluate how we manage these patients and also to explore different management approaches. There has been a big move, as mentioned, towards remote consultations in both primary and secondary care. And I personally feel that we are likely to see an increase in the utilization of remote consultations in selected situations, even after the pandemic has passed. We may also see an increase in remote therapies, such as pulmonary rehabilitation, which may actually be more appropriate and desirable for certain patients, particularly those who are quite debilitated with the disease. The area of remote monitoring has significantly developed in recent years to allow us to monitor our patients, for example, oxygen saturation monitoring, remotely to facilitate earlier detection of exacerbations and also to facilitate safer and earlier hospital discharges. The move to expand community and integrated COPD care predated the pandemic, and this is likely to develop further in line with current government policy. The future therapeutic approach to COPD care is likely to be based on a more targeted approach. For example, there are ongoing clinical trials evaluating anti-IL-5 therapy, which has been shown to be quite effective in asthma in patients with COPD and high blood eosinophil counts. The phase 3 Reliance trial is evaluating the effects of azithromycin and roflumilast in patients with recurrent exacerbations of COPD. And also stem cell therapy has shown promising initial results, but clinical trials are ongoing. So that brings me to the end of this presentation. I think I've a little bit more time left, so I'll be happy to take some.
Take a throat swab looking for the presence of strep. And we won't usually wait for that swab. If we suspect scarlet fever, we'll make a clinical decision to treat with antibiotics, again, as per the guidelines, penicillin in the absence of penicillin allergy. Sinusitis is something we see often in primary care, and I think the really important message I want to get across about sinusitis is that it is a very small proportion of it only are bacterial in nature, so it mostly does not require antibiotics. most people with any common cold will get sinusitis symptoms or pain and pressure in the sinuses because they are linked to the nose. We have 3 pairs of sinuses, and people with allergies to pollen, dust, and so on will often have chronic rhinosinusitis. So we really need to treat the symptoms. So if people have allergies, using steroid nose sprays and antihistamines and saline rinses can help. If it's sinusitis in the context of a viral infection, simple pain relief, decongestants if they're suitable for the particular patient, and again, saline rinses can all give symptomatic relief. And it's really only cases of sinus symptoms that are persisting for more than 10 days, really more than 2 weeks, where it's worsening rather than improving. And this can happen in the case where a viral infection causes congestion in the sinuses, and then the kind of stagnant mucus in the sinuses can lead to a bacterial infection, but probably in about only 3% of cases of sinus symptoms. So in those cases, the discharge will tend to become purulent, will be very low. With 10 minutes from well, pain face as well. And the despite progression. Research, I get people see that. And you're most infection and so it's happy and actually so it is kind of bacterial or really affected their just and so not as well. Infection is definitely this is and somebody take things for apes that's here it's extremely intensely present articles application fails a lot we don't so increased work of breathing, and again, that doesn't tell us whether it's viral or bacterial, but just that the infection is more likely to have gone into the chest. It's much harder to appreciate any focal crepitations in the small chest of a child. So it's really more the presence of persistent fevers and the child appearing unwell. Generally, that may lead us to suspect a bacterial infection, but we have to make a call on it. And if we are concerned in either adults or children about the person being particularly unwell with any kind of significant respiratory distress or reduced oxygen saturations or any signs of sepsis or possible progression to that based on their vital signs, we will transfer that patient to hospital. But really the majority of lower respiratory tract infections that are community-acquired pneumonias, many of those can be managed at home and if necessary with oral antibiotics if the cause is thought to be bacterial. Okay, we do have the option of arranging chest x-rays in primary care, but it's not something we can always get quickly. And remember, in primary care, we don't get to see the x-ray. In fact, I feel I'm most likely de-skilled in reading chest x-rays. It's many years since I have read one in the hospital, so we can order them and we get the report back. But the time that takes, means that we really need to make a clinical decision, and the chest x-ray report will just be some additional information. So infective exacerbation of COPD, that's chronic obstructive pulmonary disease. Again, normally we'd see plenty of this in the winter and didn't. It was a whole lot less this year. So these are people with existing lung disease, and they can have flares caused either by viral or bacterial causes. And again, we judge based on their symptoms, mainly whether we think it's viral or bacterial. We have to kind of take into account their existing symptoms. So most people with this condition will have, a normal level of shortness of breath or a daily production of sputum. And what we're trying to get from the history is how much they're deviating from their normal. So, are they producing more sputum than normal? Has it changed in colour to become more green or dirty? Are they more short of breath than they normally are? And of course, then other factors like fever or changes or reduction in their oxygen saturations. So we need to make a call. If we think it's viral, we may just optimize their inhalers and often give a short course of oral steroids. And if it's bacterial, we're going to recommend a course of antibiotics as well. And in a more vulnerable patient or who is more unwell, particularly with low saturations, they may require hospitalization. But the majority of these infective exacerbations are managed in the community, by the GP. So just to mention notifiable diseases, so in the context of the respiratory illnesses, measles, mumps, and pertussis, which is whooping cough, are all notifiable. So that means that as physicians, we have a role, and other healthcare professionals may also have a role in notifying public health if we diagnose them. Measles, amazingly, is something I've never seen, and that's in more than 10 years in general practice and several years in pediatric hospital medicine. So I hope I'd recognise it if I saw it. Mumps is something we do see a few cases of most years. And pertussis, we don't see it terribly often, but outbreaks do occur. And we do vaccinate all pregnant women now in order to protect their newborns. And then from 2 months of age, it is included in the childhood vaccination schedule. So I'll just, before I move on, I'm just going to quickly show you the notifiable diseases. So I'll share my screen with you again. This is a site that would be worth looking at. So it's the HSPC site, which many people are now familiar with for all the COVID information that has been on it. So this is all the current list of notifiable diseases. So the respiratory ones, I mentioned some of them, and then there's some sexually transmitted infections as well. I'll just move back to my slides. So just a couple of other common childhood infections. So this little guy has a vesicular rash, that's vesicles, which are blisters on top of papules, which are red spots. These are very itchy, and this is usually preceded by a runny nose and often some low-grade fever. So this is varicella zoster virus or chickenpox. So this was always a rite of passage for children. In Ireland, it's still not included in our childhood immunisation schedule, although the vaccine is available privately for those who can afford it. So this is generally a fairly mild self-limiting illness, although complications such as pneumonia and encephalitis can occur. This is another rite of passage for most children. So again, vesiculopapular lesions on the soles of the feet, the hands, around the mouth, and often on the buttocks as well. So this is hand, foot, and mouth disease. Very common, again, usually mild and self-limiting, mostly caused by Coxsackie viruses. It's generally only seen in children, although we do occasionally see a parent contracting it if they're not immune, and they tend to get a worse dose. And it's just really supportive and symptomatic treatment. So I'm going to move on to skin infections, which we see a lot of in primary care. So these little lesions that are crusty yellow lesions on the face, this is impetigo. We see this much more often in children, particularly preschool age, where they spread it by touching each other's faces. It's one of the things the crashes hate to see coming because it is so infectious. We can treat it if it's very localized with topical antibiotic, but generally any larger lesions or patches will require oral antibiotics to clear it. So these little kind of pearly raised lesions with a central umbilicus are molluscum contagiosum, very common in children. Children again spread them by touch and will also self-inoculate themselves. If they get one lesion by rubbing or scratching it, they will spread it. So we often see a cluster in an area like this. There's no specific treatment for them. They usually don't cause much bother, although they can be a bit unsightly and itchy as well. Sometimes little areas can become infected with a bacteria such as Staphylococcus. But generally, we just advise parents that they're self-limiting and will resolve in 6 to 12 months. Cryotherapy, which is liquid nitrogen, is sometimes used, but mostly not necessary. So I'm not going to go into this particular condition in any detail because I know it's been covered elsewhere, but we see a red, I can tell you it'll be hot and probably swollen limb with very extensive erythema from the just below the knee to the forefoot, and it looks like it's probably circumferential or almost circumferential around the leg. So this is a very extensive lower limb cellulitis, and really this patient just needs hospitalization and IV antibiotics. We do sometimes, with more localized areas of cellulitis, which is skin infection, we may treat with oral antibiotics in the community if the patient is otherwise well, with no tachycardia, no fever. But if we are treating a localized cellulitis, we need very clear follow-up. We need to delineate the area, and if it's extending or not responding to the oral antibiotics, that person needs intervention in hospital. But in this case, the patient needs IV antibiotics. So I just have a picture of an ulcer here. So I won't get into any detail on ulcers, but it's just to bear in mind that lesions such as ulcers or wounds, for example, cesarean section wounds or other wounds from lesions removed, can present a bit of a conundrum in terms of whether there is infection present or not. So while we are watching something heal, we need to watch out for infection. And certainly if any of our nursing colleagues are here, our GP nurses and public health nurses do a lot of work in terms of dressing ulcers. And often if there's any early signs of infection, an antiseptic dressing such as Inidine can stave it off. But if we are seeing any increase in erythema, increase in pain, increase in exudate, particularly if it has an odor, we need to consider infection. If we're just watching and waiting, sometimes sending a bacterial swab can be helpful, sending it off to the microbiology lab and seeing what it comes back as. But again, we're in that tricky situation that there can be colonization without infection. So whatever the swab comes back as, we must interpret it in the clinical context and make a decision about antibiotics. So this vesicular rash again, in a stripe on one side of the body, it looks quite angry and it's probably very painful. So this is herpes zoster or shingles. We see a lot of it in primary care. 10% of our patients over the age of 50 will get this at some point, and we do occasionally see it in younger adults and children as well. So this is reactivation of the patient's old chickenpox virus, which was residing in the nerve roots. And the treatment is mostly symptomatic. There is an antiviral treatment, but in order for it to be effective, it must be commenced within 5 days of the rash appearing. And certainly I find very often when patients present, they're beyond the 5-day mark because often the rash can be quite mild and put down to something else by the patient for the first couple of days. I find it very useful to refer to a map of the dermatomes. Shingles is usually quite obvious clinically, but sometimes if we're seeing maybe a patch in 2 different areas of the body, like the chest and the arm, a map of the dermatomes can remind us that it is all localized within a single dermatome. So this little guy has dry, scaly skin. It looks quite inflamed and some areas are quite red. So he has atopic eczema, which may or may not be infected. I think some areas in his case look like they probably are. It's not always straightforward. But kids with eczema, their skin is colonized with more bacteria, usually staphylococcal types, and because their skin barrier is impaired, they're more vulnerable to skin infections. And if we have angry-looking patches of eczema that are not responding to optimum use of topical steroids and emollients, we need to consider infection. And particularly if there's any yellow crusting, we know that bacterial infection is present and must use antibiotics. These can be topical in milder infections, and if it's more severe, we need to use oral antibiotics. This picture is the only image in this talk that doesn't have an acknowledgement, because that's my daughter's heel. So this is a verruca, and it's caused by the human papillomavirus. So this is an almost ubiquitous infection of childhood, and we see it a lot in general practice. We often use scraping with a blade followed by cryotherapy, but certainly recent evidence has shown that that's really not very effective, and I suppose we often have had to do multiple sessions in order to sort out a verruca. It's much more effective for other skin lesions. And there is some evidence now for simple duct tape, which has been tried over the years, and topical salicylic acid can be effective as well. Of course, this virus also causes genital warts, different subtypes of it, and it can cause changes in the cervix and also in a genital area, which can increase the risk of certain cancers. So this is inflammation, kind of white scaly inflammation between the toes. So this is tinea pedis, and we treat this with hygiene, keeping the foot clean and dry with topical antifungals. And we also get tinea corporis, which is ringworm, discoid patches on the body, tinea cruris in the groin or other creases, and tinea capitis on the scalp. So this is a really common infection and can be really resistant, and also we can get it in the nails, which are very difficult to treat. So here we have something in the toe, the first metatarsophallanggeal joint. It's red, hot and swollen. So is this infection? So we're certainly ticking the box for the 5 cardinal signs of inflammation. But as we said before, inflammation does not equal infection. So in this case, this patient has gout, which is not an infection. It's a deposition of urate crystals in the joint, causing extreme pain and redness, heat and swelling. Bear in mind, we need to be confident that it's gout to make this diagnosis and treat it as such. Anyone presenting to us with a red, hot, swollen joint is really septic arthritis until we can satisfactorily rule it out. So in this case, it's in the very classic site for gout, but even with that, we should check with the patient, have they had any history of fevers, and do a temperature measurement in clinic and a heart rate as well. If there's any doubt, if it's an atypical location, if it's a different joint, or if there's any uncertainty about the patient having any features of infection, they should be sent to hospital where they can have tests done with a good turnaround time, white cell count, CRP, and so on, if infection is felt to be a possibility. Okay, but if you're confident it's gout, we treat it as gout, and that's usually with either anti-inflammatories or steroids. And that's not infection. So this is just reminding us about our assessment or vital signs. So eye infections are another fairly common type of infection that we see. The picture I have here is another one to remind us of the difference between infection and non-infection. So this is a red inflamed conjunctiva, so therefore it is conjunctivitis, but itis is inflammation. It does not mean infection necessarily. So, for example, patients who get hay fever, allergies to pollen and so on, will have allergic conjunctivitis, where the surface of the eye is red, inflamed and very irritated. And that's treated with antihistamines and special antihistamine type eye drops. Whereas if there's infection, the presentation is usually a little different, but it may look very similar. And we will treat, if we think there is bacterial conjunctivitis as the cause of redness, we will treat with topical antibiotics. And bear in mind any more serious causes of a painful red eye. So conjunctivitis will usually just cause a bit of grittiness, whereas if the patient is experiencing significant pain, there can be other causes, iritis and so on, that needs urgent review with an eye specialist. Again, not everything that discharges, not every eye that discharges is infected, in particular with infants who have a continually discharging eye. If the eye is not red and it's discharging, that is generally a blocked tear duct in infants. The only exception to that, is that infants can occasionally be infected with chlamydia or gonorrhea when they come through the birth canal, but that's really very uncommon in the developed world. Okay, so in most cases, an infant with a discharging eye, we're going to recommend that the patients just simply keep cleaning the eye. They can use saline spray in the nose, and with the time, the tear duct will open up and the discharge will clear, but it can take months. So gastrointestinal infections are another really common type that we see, by far the most common being gastroenteritis, which is usually viral. And again, in an average winter, we would see a lot of vomiting and diarrhea bugs. It's something that people often manage at home as well without presenting to their GP, or they may present to the pharmacy. We really just recommend keeping hydrated. And of course, if we're assessing the patient, we want to assess their hydration status. And that's particularly important for the smaller infants or the older patient who is more vulnerable to dehydration. We really only need to consider bacterial causes in cases that are protracted, so ongoing symptoms, diarrhea in particular, and if there's blood in the stools as well. If there's bloody diarrhea, we will immediately send a sample to the laboratory, a stool sample, where it could be examined for the bacterial causes such as Salmonella, Shigella, E. coli 0157, Yersinia, and so on. But these are really very uncommon. Rotavirus was a common cause of gastroenteritis in infants, where it was usually quite severe vomiting and diarrhea. The majority of cases were just dealt with at home, and kids would kind of pull through after a few days, but a small proportion of these would be admitted to the children's hospitals every year for IV rehydration. And now in the last couple of years, the rotavirus oral vaccine has been added to our infant immunization schedule, which has been a very positive development. Urinary infections are really common in primary care. I think we'd always feel that it's not Friday afternoon without at least one patient presenting with a bout of cystitis. So we divide them into lower tract infections and upper tract infections. And most of what we see are lower urinary tract infections. So these typically present with urinary symptoms. So passing urine more frequently, stinging passing urine, sometimes some blood or dilute blood in the urine as well. We do always ask about more systemic features. Often people might feel mildly unwell, but we want to check, do they feel very unwell, vomiting, fevers, or anything like that? And we examine. We check for tenderness over the kidneys. We check for any fever, and we check the heart rate for fast heart rate or tachycardia as well. And we'll always examine a urine sample with a urine dipstick. And if infection is present, we will generally see leukocytes, which are white cells, often nitrites as well, and sometimes protein or blood. So if we diagnose a urinary infection, we will again follow the antimicrobial prescribing guidelines to guide us with the most appropriate antibiotic. For this, we will send a sterile midstream urine sample to the lab for microscopy, culture, and sensitivity. But mostly we will make our clinical decision on the day, and this result from the lab, which will come back later, may guide our treatment subsequently. For example, if the person doesn't respond to the first dose of antibiotics or the first course. So we need to watch out for upper tract urinary infections, which will typically involve either vomiting or fever, and the patient will be quite unwell, tender over the kidneys on either or both sides. So this can progress to pyelonephritis, which is a significant upper tract urinary infection, and most cases of this will require hospitalization and IV antibiotics. In primary care, we can make a judgment in a patient who is otherwise quite healthy and well, who has the early signs of upper tract infection. We can follow the appropriate guidelines for specific antibiotic treatment and watch and wait. And we need to give these patients very clear instructions and often a letter to hold that if their symptoms worsen out of hours or aren't responding to the antibiotic, that they must then present to the emergency department. So we need to be very, very clear. Anybody with blood in the urine with a urine infection, we must arrange to get a follow-up sample to ensure that blood has resolved following antibiotic treatment. And the purpose of that is to make sure we don't miss any underlying malignancy as a cause of blood. In terms of prevention, we see a lot of urinary infections in women postmenopausal women because of the weakness of their pelvic floor. And these are most typically lower tract infections. And in these patients, we would often have used in the past preventative antibiotics, which are prophylactic, a low dose taken at night. But really, the evidence has shown that this is not very effective, and we are doing this less and less. And in fact, topical estrogen given as a vaginal pessary, so the local effect of that seems to be very beneficial. And we find that women have quite reduced frequency of urine infections with this method, and there's increasing evidence for this. So I'm only going to briefly mention genital infections. So we do see a lot of genital infections in primary care, but this is really another whole talk in itself. So we aim to screen for sexually transmitted infections and encourage patients who have had unprotected sex or have had a new partner or change of partner to routinely attend for STI screens. Of course, if anyone has any symptoms of a sexually transmitted infection, they should present. And we also need to consider this in people with urinary symptoms as well. So somebody with stinging or burning passing urine may not have a urinary infection, but may in fact have chlamydia or gonorrhea. Okay, and just to mention again the notifiable diseases. So chlamydia, gonorrhea, and genital warts are all notifiable diseases. Gonorrhea specifically should be referred to a specialist clinic. So even though we often may see it, or not often, we see chlamydia and genital warts a lot more often, but we do see gonorrhea in general practice. But for a lot of reasons, this needs to be dealt with in specialist services. We do see plenty of non-sexually transmitted genital infections too. Candida would be the commonest one in women, very much in particular. It can be passed sexually between a couple. So if a woman who is in a relationship has candida that's difficult to treat, we will recommend that her partner be treated also. We see bacterial vaginosis as well quite commonly, which is non-sexually transmitted imbalance of the vulvovaginal bacteria. I said we would mention special groups and what we need to focus on. So infants and children are most definitely a special group that need to be treated differently. So it's important to bear in mind that newborn infants, really up to about 3 months of age, may not mount a fever with an infection. If an infant below 3 months of age does present with fever, this is abnormal. Okay, so small infants do not get the normal common viral illnesses, and if they have a fever, there's a much higher likelihood that it's actually a serious bacterial infection or sepsis causing it. So every infant under 3 months with fever should be sent immediately to the children's emergency department for assessment. And from 3 to 6 months, I would have a very low threshold for that as well. This is actually not something we see often at all, and we need to act very carefully. Infants who are 6 months and above, so 6 months up to school age, will have fevers very commonly, and we deal with many of these in a normal year, but much less in the last year, which has been anything but normal. So we reassure parents if they feel their child is having multiple viral illnesses. We do reassure them that in this age group, it's quite normal to have up to 10 viral illnesses per year, which of course is a lot. And then once they reach school age, this usually reduces quite a bit. I want to bring you to the NICE traffic light system, another just really useful resource that I'd like you to become familiar with if you're not already. So I'm just going to bring that up. So this is a guide for dealing with children with feverish illness and how to pick out which of those are at high risk of serious illness. So the green ones are children with a fever who have normal colour, they're responsive, they're otherwise well, and we've really got very little concerns about those. The intermediate risk ones, are reduced responsiveness or increased respiratory rate, so that's their increased rate of breathing, increased heart rate. Their capillary refill time is prolonged, so that's another vital sign that we will always check in children, and if it's prolonged, it indicates reduced perfusion. The red ones are the ones we're very concerned about, and usually these will need urgent attention and transfer to hospital. So very fast respiratory rate, very fast heart rate, very unresponsive, or pale, mottled or blue. So all of these are very concerning. And within this category, they have the age less than 3 months with a temperature of 38 and above. Okay, so that's why they fall into that group, regardless of any other signs. Okay. I'm going to pop back up my slides. So really in terms of infants and children, it's just to bear in mind the special treatment for those younger age groups. They need special attention, and just always bear in mind that even though mild self-limiting viral illnesses are common in children, there is always the possibility of a more serious illness. And if we are thorough in making sure that in every child with a fever, we take their heart rate, their respiratory rate, their capillary refill time, their temperature, and pay attention to their overall appearance, and also listen to the parents, we're much less likely to miss anything serious. And we're going to follow up and safety net, even if it seems mild. Get back in touch if things get any worse. Another special group is the elderly. So again, the very elderly may not mount a fever with infection, even with sepsis. And sometimes their symptoms are very non-specific. So we often see urinary tract infections in the elderly, men or women, presenting with confusion. So that's a common phenomenon. The risk of sepsis is higher with elderly people than with younger adults. And we have to bear in mind they're often on multiple medications. There's a risk of interactions, and they may well have renal impairment. So we have to bear that in mind with our prescribing choices. Pregnant women are another special group. Infections in pregnancy do need treatment also, but we must select ones that are considered safe in pregnancy. Pregnancy is considered to be a state of relative immunosuppression. UTIs are commoner. We give dietary advice to reduce the risk of listeriosis, and the flu vaccine is recommended, as for all our at-risk groups. So, of course, immunocompromised individuals are important as well. So this will be patients on immunosuppressants with any conditions that make them immunosuppressed, patients without a spleen or without a functioning spleen, and of course, don't forget patients with diabetes who are at risk, and patients with celiac also, and any really chronic diseases. Just to mention the serious infections not to miss. So it's not possible to go through all of these today, and we are dealing with the common infections primarily, but bear in mind, meningitis, meningococcal septicemia, that's something we don't want to miss in kids, and very occasionally, very rarely really, that can present in older age groups as well. Sepsis is always a possibility at any age, and thorough assessment, good history taking, and a good examination, including the vital signs, will help us to identify this. Okay, septic arthritis is another one we don't want to miss. Okay, so I'd mentioned that in the context of the red hot swollen joint. Really, any child with a limp and anyone with a fever with no known focus, think of septic arthritis. And if you suspect it, there's only one place to go, and that's the hospital for that patient. Okay. So we really want to keep reducing our antibiotic prescribing. And this is really important for any of you who are not in a prescribing role as well. It's really about educating our patients and getting a consistent message across. We want to kind of get rid of that idea that if your doctor didn't give you antibiotics, they didn't really think you were that bad. We can recognize that patients can feel very unwell and very miserable with a viral illness, and we can advise them about how to manage those symptoms. But we need to be very clear that if we don't think that the antibiotics will benefit them, there's no point in giving them. And we just need to keep getting that message across. Reduce our antibiotic prescribing, and when we are prescribing it, stick to the guidelines. And really, broad spectrum antibiotics like coamoxiclav have very little place in primary care. We use an entirely different range of antibiotics in primary care to what is used in hospital, where broad spectrum antibiotics are appropriate and commonly used in the right setting, and for the right reasons. Okay, but we're dealing, with the kind of the bulk of the iceberg, and we're dealing with the common stuff, and we have a huge role to play in reducing antibiotic resistance. So prevention, as I mentioned earlier, is a big part of our role. So vaccinating, of course, the COVID vaccine rollout is underway, but we also obviously deal with the childhood immunisation schedule, which is a huge part of our workload, and primarily the workload of our practice nurses. And we do plenty of other vaccines as well. The flu vaccine every year for all our vulnerable groups, the pneumococcal vaccination, which is against pneumococcus, which, as I mentioned earlier, is the commonest bacterial cause of pneumonia, but it also can cause a lot of other respiratory infections as well, ear infections and so on. All our infants are vaccinated against it if they partake in the vaccination schedule, but we aim to vaccinate all our over 65s, all our patients with diabetes, or anyone else in an at-risk group. Pertussis is whooping cough, so it's included in our infant vaccination schedule, but we now recommend it for women in pregnancy in order to protect their newborns in the first 2 months of life. Most GP practices do travel vaccines. HPV is now being given to boys too. In school, it's not primarily done in GPs, although we can give it to people who may be specifically at risk. I mentioned the varicella vaccine. The shingles vaccine is available, but privately only for now. So the take-home messages from this talk: if in pregnancy in order to protect their newborns in the first 2 months of life. Most GP practices do travel vaccines. HPV is now being given to boys too. In school, it's not primarily done in GPs, although we can give it to people who may be specifically at risk. I mentioned the varicella vaccine. The shingles vaccine is available, but privately only for now. So the take-home messages from this talk: if a patient presents with a possible infection, just think, is there infection or not? If you think there is, what type? Do you think it's viral, bacterial? What do you think is the causative organism? Assess the severity. And most people presenting with possible infection will need their vital signs checked, with very few exceptions. If you're going to treat it, think, can I treat the symptoms only? Or is a specific treatment needed, such as antibiotics or antivirals? And if you're going with that, consult the guidelines. So I've introduced you to the Antimicrobial Prescribing Guidelines, which many of you may be familiar with already. If you're in a prescribing role, the British National Formulary is accessible through your UCD library account and is a really fantastic resource. In every case, you're going to safely net and follow up to some degree. Infection control advice is really important, and we need to be well informed in terms of the exact kind of period of time that people must isolate if isolation is necessary. Just remember about notifiable diseases, don't forget, and remember our role in prevention. So immunization, good promotion of vaccines, and of course, good promotion of hygiene and hand hygiene especially. We now know just how effective that is. Thank you.